kind introduction. And I wanna start by expressing the gratitude for all the individuals that have joined us today. The Illinois Pediatric Learning Collaborative was established after we looked at some trends in the field. We do understand that the trend is for a lot of adult providers to come down and work with pediatrics. We understand the silos that we work in. Where there may be a struggle with coordination of care. We also understand that we may need to learn more about what other disciplines do, especially in different domains. So early intervention with the school district, inpatient, outpatient, how can we all work together? So the goal of our Illinois Pediatric Learning Collaborative was to create a forum where individuals from all domains, anybody working with children with medical complexities and or life-limiting diagnosis can come to a shared learning experience where they can also expand their network, hopefully increase our coordination of care, and ultimately our focus is to ameliorate the services that pediatric patients and their families receive in the state of Illinois. And so we're so ecstatic to have you. We're hoping that you'll join us every Thursday, uh, the third Thursday of every month between 3 and 4:30. All of the presentations will be on Zoom. They are free for individuals to attend. We do offer CUs for most professional licensures, pretty much with the exception of nurse practitioners and doctors. Unfortunately, our license didn't cover that. So we apologize to those of you who come, but you are of significant value to our conversations and hope you continue to come back. If you have any other questions or are looking to register, you can find us at the HAP website under pediatrics, or you can email me anytime. But we are super excited today to start with a conversation about legislation, and there's no better individual to do that with than with Ellen Burns. She's such a mentor to me and somebody that I admire so much. An absolute, I call her a bulldog. To me, it's a form of admiration and appreciation just with the way the diligence with what she does, her knowledge base, her ability to communicate and get things done. It's incredible. So honored to be able to speak with her today. And the two of us will be talking about these agenda items, their objectives. We're going to start with just an overview of how legislation is passed and what that process looks like so we can all get on the same page. We're going to learn how to advocacy works and how to become a strong advocate. We will spend some time talking about the journey that pediatric palliative care program has taken in the state of Illinois so that we can appreciate the length of time that some very powerful individuals have put into this. And then we're going to talk about the 1915 SPA, which you'll learn all about. And then we're going to end with different legislation in the state. So without further ado, somebody that is just incredible, Ellen.
Thank you, Scott. Scott calls me a bulldog. I'm sure there are a number of legislators that call me something less positive than that. Um, but I am an incredibly strong advocate for families experiencing a serious illness. And I'm really happy to meet with this group because pediatrics is, of course, a very, very important subsection of those with serious illness. So super happy to share um, kind of the big picture around advocacy and government affairs, and then hopefully equip you all with the tools to do advocacy when and how you want, because there isn't really one way to do it. And you can be empowered to do it almost any time. So hopefully you guys will learn something. This is pretty informal. So if you have a question, feel free to come off mute and ask, and we can go down whatever rabbit holes are helpful to you guys. Because that's basically the reason I'm here. So just wanted to start with kind of a big picture, right? So we have advocacy, and as an advocate, it's when a person or an organization can take action to support a cause that they, as an individual or as an organization, care about. And it's a really important part of influencing public policy. And I will tell you that at a federal level, that's sort of a different animal. But at a state level, you as citizens of Illinois have more power than you know to influence public policy in this state. It is a pretty direct process. It really is. And I've been now working in this area for 5 or 6 years, and individual people go to their local representative or state senator and come with ideas and ways to make Illinois better. And that's what they want. That's what they're looking for. So don't be shy about being an advocate at least, at the very least, at the state level. Um, yeah, actually, yeah, stay on that page just a second. So, if you want to go back just to that big picture. So, the public system of laws, regulations, and also funding that are enacted by a sector of government kind of is what creates the framework for policy. So, you have the statutes, the laws, then you have regulations that operationalize those laws, and then you have the funding that supports the agencies who have to carry out those regulations and laws. And then where these two things meet, advocacy and public policy interact, that's really most commonly where advocates get involved, contacting lawmakers regarding legislation, talking to agencies about their policies. And we've been doing quite a lot of that over the last several years. So you can go on to the first objective, Scott.
I'm going to try.
Okay.
I,
You might have to close out that little
yeah,
reminder that you've got before it'll let you go forward.
I have lost my screen. So I think I'm out and I'm coming back on.
No worries.
Sorry about that, everybody.
No worries. Okay, so first we're just going to cover kind of understanding how legislation in Illinois is passed. And so I've kind of got it set up on a timeline here. And even though the legislative session typically starts around the first of the year, I wanted to start really with the fall and winter, which is like before the session begins, because that's when we really begin to have important conversations. So this is when individual stakeholders or coalitions or organizations, they come together and decide something that needs to change in public policy in Illinois and potentially talk about whether that can be done at a regulatory level or at a changing of the law. And it's very helpful to use models of texts from other states. So we do a lot of research on like what is California doing or what is Massachusetts doing in this area that's like really outstanding that we would like to model, um, and or steal little parts of their statute to make our statutes better. So that kind of research happens. You're forming a coalition, and then you're starting to like write a text, write some language, or look into a law that already exists and make amendments to that law. And as you talk about the legislation with affected stakeholders, both within your organization and in other organizations, you begin to find areas where you need to compromise, where you need to negotiate, and where you need to, alter the text and alter the language. So that is best done in the fall and winter. And then in January and February, you actually move into the next step, which is to find a sponsor, to find a legislator who would be willing to be the champion for this piece of legislation in the Illinois General Assembly. And then that sponsor takes the legislation and puts it forward to a legislative review board, and they actually like write the change in law. They write the amendment or they write a new act to Illinois law. Um, that generally takes place in January and February. And then in February and March, the bills are introduced and considered. So that lawmaker is going to introduce the bill. They are the chief sponsor. The bill is going to go to like an assignment committee, which is sort of like an interim place. And then the assignment committee or the rules committee, depending on which chamber you're introducing the bill in, will assign it to a committee. And then there are many, many committees in the House and many committees in the Senate
Mhm.
that are basically tasked with like doing all the nitty gritty work to analyze what this change in policy would mean and whether or not it's something the General Assembly wants to do. Um, in the meantime, while it's awaiting a committee assignment or when it gets to a committee assignment, as an advocate, you're looking for co-sponsors. You're looking for other legislators who maybe have stepped up in the past and been a champion for your legislation. Maybe they've co-sponsored the bills that you had in the past that affected the same population or was looking to improve care for hospice or serious illness. And so you reach out to those lawmakers and you ask them to become co-sponsors of this bill. Um, you also, at this time, once the legislation is actually live and it's been introduced, you start hearing from a lot of different stakeholders that you maybe didn't touch base with when you were forming the legislation, and they may have changes in language that they want to see made. They may have objections to the bill. They may need you to make certain compromises, or they may just have like a really bright idea of a way that you could add to your legislation. So there are generally in February and March quite a lot of amending of these bills that happens. Um, and then they will get a vote in committee. They'll be heard in committee. Advocates, especially advocates like you all who are intimately involved with patients and families, make really wonderful witnesses in a hearing. And like they really like to hear what's really happening out there. They prefer that a lot to individuals like me who they perceive as being, paid to lobby for an organization. Um, and they always have a lot of questions. And then they take a vote. And if they vote to move your bill forward, it will go to a floor vote. And most of the time, unless it's controversial, folks do look to the judgment of the committee because the committee has research help that looks into these things and they've walked through them and heard the testimony. So once you accomplish that in one chamber of the General Assembly, you have to turn around and you have to repeat the entire thing in the second chamber. And in the second chamber, you introduce the bill. It's considered in committee. If it is able to pass out of committee successfully, it goes to the floor. And if it passes the second house, then it's going to be signed into law. That all has to happen before June 1st. And so it's very common for bills, even bills that like are positive things and have a generally consensus that people want this bill to move forward. But oftentimes you just can't get all the steps accomplished by June 1st. And so it gets bumped to another session. Then in the fall, there's a veto session in November. Generally, that's used just for very high priority bills. And bills that the governor has vetoed. And then finally, those laws over the course then of the fall of the next year or beyond are translated into regulations. So once the law is passed, signed by the governor, then the regulatory bodies that are charged with operationalizing the law kind of take over. And then they write the rules. The rules have to go out for a public comment period before they're finalized. And then at that point, the law is operational. Anybody have any questions? Okay, great. So just really quickly, this is hard. Success is hard. In a single session, the Congress of the United States they have about 10,000 bills that are introduced, and just precious few of them, aside from the budget bills and all the things that kind of get folded into the budget bills, which are, well, theoretically have to be done every year. We're our Congress is even struggling with that basic requirement, right? So very few bills end up being passed out of those 10,000 that may be introduced. And then in the General Assembly, it's about a 10% ratio. 4,000 bills are introduced and about 400 become law. So a very small handful of bills related to hospice and palliative care and medically complex illnesses with children are going to get considered in any given year. So it's really the job of the advocate to push to make sure that your bills, your issues, your policies are going to rise to the top and be considered in a committee and voted on and moved through the process, right? So it's super important to have your efforts reaching out to lawmakers to tell them you need them to pay attention to this bill. And that can be advocating for them to support a bill or advocating for them to oppose a bill, which we've also actually done a little bit of. So yeah, this is important, and it has to be a message to them that they need to do something. And a lot of the time, if you really put that effort in, they are willing to step into that space. So
And Ellen,
next,
I think it's such an important point that you make that if only 10% of the 4,000 bills that are introduced to the Illinois General Assembly are passed, a very small percentage of them will fall under early intervention, hospice and palliative care, something to do with medically complex services for children inside of the school system, or whatever the case may be. So it really, we're only 3% of the population in Illinois, but we do have unbelievable professionals. And I do believe that we can be a very strong voice to make sure that we can get these bills passed. So I love you focusing on that importance. So thank you for that.
yes. And I will say in general, like hospice and palliative care and care for pediatric children with serious illness, is not something that is partisan, generally speaking. And so there's any legislator that I've ever met with is very open to considering legislation and policy around our population. And they do view it as a very vulnerable population that is deserving of policy, deserving of state policies that make things work and keep families, from suffering and keep them whole financially. So thanks, Scott. So just a few words on kind of the secret sauce. The secret sauce is you got to work with others. It is not enough to have a great idea and think that that's going to carry that legislation all the way through the process. So I really encourage, collaborating with stakeholders. So that means identifying coalitions, advocacy organizations, and other important individuals that share your goals and priorities. Share information about your legislation with those stakeholders and why it's needed and how it helps them, why they have a stake in the legislation that you're looking to pass. And then collect input from those other stakeholders because this has to be kind of collaborative effort. We never want to say, well, this is the legislation we want, and you may disagree with this or you may have some changes that you want. We don't need your help that much. We're going to go with what we've already put down on paper, right? That's generally not a successful approach. And even where you have to we've definitely had several proposals where, okay, sorry about the dog. We've had several proposals where nursing facilities have pushed back, or the State Medical Association has pushed back, right? And so we definitely are in the business of making compromises in order to get those important organizations to sign on to our bill and agree to collaborate in getting it passed. So that collecting input and making adjustments to the bill language, reaching compromises for broad acceptance is really important. And then we always communicate with our stakeholders to tell them how they can support a bill. And the way that that happens is a process of it's called completing a witness slip
Mhm.
or slipping for a bill. And so what happens is when a bill goes to committee and is heard by the committee wants to know all the organizations in the state or even all the individuals in a state that support that bill or oppose that bill. And so they open up a process where you can complete a basic form on behalf of your organization if you're a leader of an organization, or on behalf of yourself as an individual. And you can record, it's called a record of appearance. So you don't have to show up to testify. You can complete a witness slip that says, I am behind this bill. Yes, I want this to pass, or my organization is, or I oppose it. And you can register that position with the committee. You can also put forth written testimony. So oftentimes that's super valuable, especially for busy practitioners who can't just, show up in Washington on Wednesday because that's the day of the committee meeting. So written testimony is another way to contribute as a stakeholder. And then the second group of people that we collaborate with is legislators. We always want to be identifying legislators that are on the committee because they really have the greatest say in whether that legislation is going to move to the floor of their chamber. So we try to make sure that those individuals on the committee that's hearing the bill have all the information they need. We develop fact sheets that they can have. Um, we target, as I said before, we target legislators who have supported our bills in the past. And then we're emailing these folks to answer any questions. If possible, we like to make appointments and actually have in-district meetings. But oftentimes their time just isn't going to allow for that because the bill isn't assigned to a committee until maybe a week or 2 weeks before it's going to get heard. So we don't really have time to go and meet with each of those legislators. And then finally, we want to work with
Ellen,
the
I'm going to jump
agency.
in just
Oh,
real quick.
sure. Please do.
So,
Please do.
with the legislators, it's very interesting because we work with a lot of families who are very invested in certain bills being passed or with different items that are being proposed. And so, one thing that I, that is that really has been successful in the past has been taking a family member with you, somebody who's a huge advocate for that bill that you're trying to get passed. If you do get meetings with these legislators, and to be able to hear the story, I think is where the power of our population stands. It's not trying to utilize the patient or the family. A lot of times it's making the families feel like they are actually making a difference. And so if you're talking to them about different things that are going on, asking them to come could be a very powerful piece. So thanks, Ellen.
Yeah, no, 100% agree. And I will say when you want to get a legislator's attention towards a problem, the best timing for that is over the summer and over the fall when they're not involved in a legislative session. And those district visits are really important. That's a great time to visit a legislator and request a meeting. And at those meetings, you want to bring up like, here's a problem that we need to solve with policy. And here's my idea. That's very effective in the fall. And then when we get into the session, then it's just calling and saying, here's a bill number, here's a fact sheet. I support this bill. I really want you to sign on as a co-sponsor and support the bill. So, um, you know, and again, Scott has a lot of information about how this process works. I'm always available to help your families and to help you advocate. Happy to, help in any way that I can in terms of the process. And then finally, we also work with the agencies and the legislative staff because the legislative staff does a lot of research on these bills once they get assigned to committees. So they often have questions. And the agency that will be tasked with carrying out the bill, they are a major stakeholder. And they often want changes in legislation just from a practical standpoint. They'll say, this makes sense to us. We think that this is a good bill, but you have these parts of the bill that are going to make this really difficult for us. And so we need you to make changes. And so it's super important that every agency has a legislative liaison that, I know many of them, not all of them, but it's always best to be covering that base, providing them with a policy brief, answering their questions, and making sure that if they have agency objections, that you take those into account with an amendment or something along those lines. All right, Scott, you can move on.
All right.
Awesome. So the next thing, now that you kind of have a sense of this process and how to advocate, I put together a few pointers about participating. So, ways to be an effective advocate. And this kind of is involved in like that actual meeting. Like I said, you can complete a witness slip, you can call the legislator's office and just tell them your position. That's fine. If you really want to be effective with your local lawmaker and you want to go in and do a visit, that's super important. And we do this both in Washington, D.C., usually once a year, and then we do it, on an kind of on an ongoing basis with legislators in Illinois. But it's really about being ready and willing to share your story. So, learn about the bills that are active and the, things that have been maybe introduced in, like in Illinois, like I said, so few bills get passed, right? So a bill may have not made it all the way through the process or didn't float to the top, but it's still something you're passionate about. You have the entire summer and fall to get in and talk to the legislator about that bill. So when it's reintroduced, it'll have a new bill number, but it's still the same issue and it may be a good policy solution. So know what's really important when you're meeting with a legislator is know how this problem affects you or the person you're advocating for if it's a patient, um, and then know why you're supporting it, right? You do have to come in and be educated because they have 4,000 bills in a session.
Mm,
They're not going to be able to by memory, pull that idea of that bill out and know what it's about and know why they should listen. So you do have to have some good solid background knowledge about your bill and how it impacts you, or your constituents. And then respond to requests to complete a witness slip. Like we will oftentimes send out emails to our stakeholders and to individuals, like our hospice providers, and just say, this bill is going to committee in the next 2 or 3 days. We need you. Here's the link. Here's the process. Please sign a witness slip. Um, Email your local legislator, attend a district meeting, attend a lobby day in Springfield. So I would say like that's not really a very long list. It's some one of those four things or a couple of those four things is really the best way to participate. Okay, next slide. Yeah, and then I've just basically kind of laid out the rough agenda for a legislative meeting. So you can come back to these if you're ever planning to work with a family member to meet with a legislator. Um, there's basically an introduction, and some people miss this, but like telling them your name and your address, right? They want to know that you are a voter, that you are a constituent and you live in their district or you work in their district, right? Your organization provides services in their district. So that's a very important thing to tell them. Tell them the name of your organization, your role, and again, where the organization provides care. For hospice and palliative care, we always sort of ask them about any direct experience they have with a family member or a friend who has had a serious illness. We ask them, to tell a story about any experience that they've had. And it allows them to kind of conjure up a picture that is really helpful as a starting point. Um, and then it's really
and I think we
important.
have the power. We have the power for
Yeah.
that, right? As providers, so when we've met in the past with LaHood or Mary Miller or some of the other ones in these smaller communities, we're talking about the fact there's no real providers in the community. We're talking about the service deserts that they're experiencing or the limited ability to discharge from the hospital to a pediatric specific provider. So the story for providers can utilize your knowledge from working in the field to really paint a picture that almost mandates their support. So I say that to hopefully encourage you to be confident that you do possess the knowledge of these stories. If you're not going with other individuals, you are the experts, right? I know it's kind of the way is like we're not the expert, the family's the expert. I always challenge that by saying if your kid was sick, would you want an expert? And it's okay for them to say, "Hey, I'm an expert in hospice and palliative care or in or early intervention." It's okay to say that. So when you go in there, you are experts in this, and please feel confident in it. Sorry, Ellen.
Yeah, and it's also obvious that pa parents of a seriously ill child generally do not have the time and space in their lives to show up at a district meeting. So I think they are very willing to hear those stories told by their, medical providers and others that are caring for them. So, but that story piece is really important. That brings the problem really to light, and the value of the services that we offer in hospice and palliative care and care for complex illness. You can paint a very vivid picture of why that's so important. So once you kind of like set the stage with that story, then you can move into a policy or two. It's always best to limit it to about two. And the pattern there, it's really just a pattern where you're explaining the problem, you're explaining how that problem impacts your organization or you as a provider or the patients that you serve. Ultimately, how it translates to patient care, right? So we talk a lot about workforce problems, right? Workforce problems affect hospices, but ultimately they affect patients. So it's pulling the story through to get to that patient care, quality of care, availability of care, um, uh, affordability of care, all of those things translate to the patient eventually. Um, so what's the problem? How does it impact your organization or your constituents? And then what is your legislative proposal to solve that problem, right? What is the bill number? What are you proposing in the bill? How does it solve the problem? And then finally, at the end of each policy issue that you're bringing up, you want to ask the legislator to do something, right? So many times with a piece of legislation, we're saying, would you please consider signing on as a co-sponsor for the bill? Or we know that you're going to be hearing this bill in committee. Would you please give it a yes vote so it can make it to the floor and, become law in Illinois? But you should not be shy. You always say, I would respectfully ask you to consider, or I really hope you will. You can soften the ask, but the ask should be very clear at the end of each of these conversations. And they were expecting it, right? So don't pull the punch. And then you may cover a second policy issue with that same pattern. And then there may be like, okay, so let's talk next steps. Is there anything more that you need from me? When can I follow up with you? Um, and then thank them. The biggest and most important thing is to thank them. And that's it. It's like everybody can do this, I promise.
Well, it's interesting because the we were told in DC, Ellen, that the most important aspect of these conversations are that you follow up because they do get so many requests. So
Yep.
make sure that if you're meeting with a staffer, and maybe not the actual senator or representative, but you're talking to the staffer who's in communication with them, getting their card, making sure we're emailing, making sure we're following up to keep it on top of the list is so important. So please make sure that step is completed if you're doing any advocacy.
Yeah, they appreciate the reminders. They don't mind reminders as long as they're done respectfully and you're not like counting them every few days. So there's a nice balance there, but they appreciate the follow-up. All right. So I was just going to walk through the pediatric palliative care legislation as sort of an example. And some of you may be pretty aware of this history, but a law that required the state Medicaid agency to do a pilot of a pediatric palliative care benefit was passed in 2011. That's how far back the effort goes. And it was actually passed and became law, but we hit the skids when we did not, for several years, have a state budget at all.
That's right.
And so then the state was just paying the bills that it legally had to pay. And there was no funding to conduct the pediatric palliative care pilot. And then the law had a sunset clause in it. And so it sunsetted, and nothing was ever done. Then a law requiring a full benefit of pediatric palliative care in the Medicaid program. It required the state to seek a waiver or authorization of another kind from the federal government to run a statewide pediatric palliative care benefit under Medicaid. And that started in 2018 and passed into law in 2020. So that was still quite a journey of, I think we introduced it in 3 different Illinois General Assembly sessions before it was passed unanimously on the 3rd try. So persistence is usually rewarded. So then the law requiring, then the following year, the legislator who had worked with us on the Medicaid benefit asked if we could help her to promote and advocate for a law requiring private insurance to cover pediatric palliative care benefits. And that law passed in 2022. A little bit of a hiccup, though, is that that requirement was that the benefit offered by private insurance was to mirror the benefit offered under Medicaid. And, technically, we still don't have a benefit under Medicaid. So, but despite that, insurance companies are supposed, private insurance companies that are regulated by the state of Illinois, which is not everybody, right? So it's not big employers who do their own insurance. The law doesn't, Illinois can't make requirements for those plans. But for plans offered on the ACA, plans that are regulated by the state of Illinois, private health insurance is supposed to pay for pediatric palliative care. So that was the second law that was passed a year later. And then the waiver that asked CMS to approve authorization to run the pediatric palliative care benefit, that was submitted to CMS in 2023. So between 2021 and 2023, we worked with the Department of Healthcare and Family Services to write up this waiver. And a waiver is just simply an authorization from the federal government to run this program in Medicaid. We have to have that authorization in some form because CMS, the federal government, pays half of the bill for our Medicaid patients, right, and their benefits. So we met as stakeholders. Stakeholders met with HFS staff. We provided a lot of resources about other state palliative care programs and what they're doing. We evaluated their draft documents and gave them advice. And then finally, the waiver was submitted in 2023. And here we sit 3 years later. And we do not have a pediatric palliative care benefit yet, which is very disturbing. But this is, I would like to, it would be sad if I was saying like, this is an outlier, they've just really let us down. But the truth is, there are many waivers that have taken the state many years to get going. I don't know about the waiver for children with medically complex conditions and technology dependent, that I don't know how long that waiver took from the time it was passed to the time it was implemented. But I know that the waivers that support families and children with mental health issues, the mental health waivers, have taken a very long time to go from concept to actual operation. Any questions about this journey or comments if you were involved in it? Okay, great.
And I think we're getting to the exciting part, right? So what we wanted to do with this presentation is give you an overview. So we talked about advocacy, how bills get passed. We talked about how to be an advocate. Now we're starting to hone into what's going on with the state. And I think this last one, where CMS is responding and pending, and as we move forward, we're going to talk about the actual pediatric palliative care program and other state bills that are passed. So this is going to talk to your job specifically. I do think the fact that we're having ongoing communication, that people are still working to get this passed is very positive, right? It takes a long time, but if we don't look at the positive, we'll, experience some burnout, some frustration. And so what Ellen's talking about is we're really standing on the shoulders of giants who have wrote I think it was Kim Downing and a couple others who wrote it back in 2007 to get it passed in 2011. And this whole process is just unbelievable advocates, Kristen James, Aaron Flanagan, the people that have been just really doing this forever, and it's starting to look like we're making some progress. So I did get, Ellen and I did get an email from HFS saying that they're continuing communication with CMS in order to answer any questions they have so they can get final approval. And in the meantime, we're working hard to get the bones of the program created so that when they do get passed, it can start to get implemented in a timely fashion instead of starting that process afterwards. So there are some things to be excited about.
Yeah, for sure. So I think these next few slides are going to be kind of interaction between Scott and I, and please bring up questions because this is really where the rubber is going to hit the road for you all.
Mhm.
If you have patients that will be able to take advantage of the waiver or it's phrased as a waiver, but it's really a state plan amendment because it's a statewide benefit. HFS, they chose to implement this program with federal authority under a 1915 I waiver. So that's an optional home and community-based services benefit that allows the state to create flexible service packages and target a specific population of customers based on certain conditions and needs. So it's just one type of waiver, but that in this case is also a state plan amendment. So they picked that, and for the most part, it seems to be a vehicle that will work well for the authority, and so we're just waiting for it to be approved. The state benefit obviously must align with federal guidelines for a 1915 I waiver. And so for that waiver, the federal government requires that the benefits are made available statewide to all eligible customers. It ensures that persons performing the evaluations for eligibility assessment and planning of care are independent and unbiased. So those have to be, that has to be a conflict-free situation that is determining if that patient can participate. They provide the benefit to customers who reside and receive services in their homes and communities. So we did have a discussion about like sometimes patients go into the hospital for a long time and what do we do there? And because this is not, they cannot receive this benefit, these waiver services, if they're in an institution or if they're in the hospital. So that's a little bit of a tricky one for this population. But HFS is well aware of that trickiness and willing to work with us on that. An evaluation and eligibility process that is based upon established needs-based criteria. So this couldn't just be about a diagnosis with a serious illness. Under this waiver, it has to be two parts. It has to be the serious illness and it has to be needs-based functional criteria. The service planning process is patient-centered, and it also requires us to set up some type of a quality assurance and monitoring process to go along with the services. And then finally, CMS must approve it, and they haven't yet, but I hope they will. So any questions? Like that's kind of all about the CMS authority side of it, and then we'll get into the provisions in the waiver. Any questions though?
I can ask a question, and this is probably really, really dumb, but basically the waiver is asking that this benefit, the state is allowed to administer this benefit, even though we get federal dollars to support it.
Right. That's right.
Okay.
And
Because
Dr.
of the,
Miner, we'll go through how it trickles down from like HFS to the other entities and how it will be administered in a couple of slides.
yeah. But CMS has to give their blessing because they pay the matching dollars. It's a
Yeah,
great question,
yeah.
Doctor.
Illinois can't afford to manage this, right? So the CMS is imperative that for this program to function.
Well, I will say, in contrast to like one of the states that has a program I admire greatly is, I believe, Massachusetts.
Yeah.
So they did not go through a waiver. They set up an entirely separate budget line to pay for pediatric palliative care. And they, whatever money they can get into that budget, it started out at like $5 million. And they said, okay, we can pay for pediatric palliative care for, 100 kids,
Yeah.
the top priorities with our $5 million. And then the next year they got 6 million, and the next year they got 12 million. So their program is run under its own budget line. They didn't need a waiver. They can, it gives them a lot of flexibility. Um, and so it's like, it's very interesting as you compare state to state and you say, well, why can't we do what they're doing? Their program works great. But the way that we get to these benefits through authority from CMS or not makes a big difference in sort of how these things can be done. So just an example.
I have a quick question. So when you say it can't be, it's not for kids in institutions, so our kids in long-term facilities like Marion, Mark, anything like a long-term facility cannot receive this? It's only for home-based?
Correct. They are not eligible under this waiver authority.
Yep.
Yeah. So that was definitely, less than ideal. Now again, so you're all, and there is always that opportunity that the patient who is in an institution, living in an institution, can receive hospice care with along with curative care, right?
Mhm.
So that would be the road to go. I know that's not always an easy conversation or the right fit for the family. But unfortunately, under this waiver program, they wouldn't be eligible for the benefit.
Yeah, so Sheila, some of those cases that we've worked in the past where we would monitor some of those individuals at a long-term facility in a palliative fashion, that those individuals just wouldn't qualify.
For the Medicaid benefit piece.
Yeah,
Yeah,
for this one, yeah. So,
right.
but Patrice, this is where it gets exciting because people have really advocated to get an extensive aspect of of what is going on or who can help under this benefit. And so these therapeutic serious, and we see you, Megan, in just a second. So the therapeutic serious illness and bereavement support would be covered under this PPCP benefit. And so would Megan then. So some of that therapeutic serious illness would be in addition, if I'm reading the thing correctly, you already get the social work services going in, but if you do have a child life specialist or an individual, so you have music art that may go in there, they can get fee for service under this benefit.
Okay.
And so it's super exciting, right? Because if it, for so now the conversation in the future was going to have to go, when does the anticipatory grief come in, and how are teams working together in order to make sure that we're getting some of that bereavement in there when the families need it
Mhm.
the most. It's incredible that this waiver would allow that, right?
Yeah. And it is it open-ended, like we get to assess and decide what they need and that's what we get to provide, or is that just not defined yet?
There are
Yeah.
limitations in the waiver in terms of like the number of days of respite or um, the length of time that bereavement can continue after the child's death. So there are some limitations. Um, and
And
I
there's
don't know
limitations
them
to the
off the top of my
amount.
head.
Yeah, there's limitations to the amount of times you can go in a month too, right? So like it would say, hey, 3 times a month. I'll send you a cheat sheet that we created,
Yeah,
and it goes through how often you could go. And I do
yeah,
believe that bereavement services has a limit on how long afterwards. I believe it's a year, but that's I'm pontificating, right?
yeah,
So that's just off the top of my head. So I'll send you that and make sure that you have a
yeah.
copy so that you can look at it. You don't have to read the entire thing. It's just bullet points.
So it's not that we would get in trouble if we did more than that. We just wouldn't be able
Yes,
to bill
there you
for it,
go.
which
I
we're
love
Correct.
that
gonna do it
creativity,
anyway.
Patrice.
Yeah,
Yeah.
we'll do it anyway. Yeah.
Fantastic. Yes, indeed.
Any other
Uh,
questions? I know somebody had their hand up. Are there any other questions?
Ms. Megan?
Oh, yeah, thank you. I mean, you guys kind of answered it, but just to piggyback off of Sheila's question, so for our kiddos living in, institutions or facilities, obviously we still deliver palliative care, but the organization that's providing it just doesn't
Yeah.
get reimbursed.
Yeah. So like Alden Village and things like that, Merkland, you're looking at doing the same thing that Lightways is already doing with the pro bono work.
Yeah. I'm going to back up a second and just, because I don't think it's on the slides. Under this waiver authority, th- receiving a pediatric palliative care benefit under Medicaid does not preclude the child getting other waiver benefits,
Yeah.
right? So if they're already part of a waiver program, these overlap, right? They can't overlap in services,
Mhm.
but you don't lose any benefits under you you can't be duplicative, but you don't lose any benefits under another waiver program.
So
Is
Megan,
that
what that would look like is you can have individuals with that are involved with DSCC that are also receiving the palliative care services through your organization. And then obviously we're using Megan and her team as an example, but throughout the state, if there's providers throughout the state that are looking to work with children with medical complexities that are medically fragile and technically, dependent, you can have both of those services within a home as long as you're making sure to differentiate what those services look like.
Yeah, great. So a few more details without getting into, all of the nitty-gritty. The child must be under the age of 21, diagnosed by a physician with a serious illness, and determined to meet the functional needs criteria under the waiver. Children need to be reevaluated for ongoing eligibility every 12 months. And HFS will complete all evaluations and reevaluations for eligibility for the pediatric palliative care program using the child's most current Illinois Pediatric Patient Review Instrument, which is a specific form instrument that the state created. And really that evaluation and reevaluation has to do with the requirement under this type of waiver that there is an independent assessment of the patient's eligibility. Services are like again, this is like where the big changes, right? It's not just you can bill for a doctor visit or you can bill for a nurse practitioner visit or a licensed social worker. You can bill for pain and symptom management,
Yes.
expressive therapies, therapeutic serious illness and bereavement support, and respite care. So
And
those services are all part of the package.
And Child Life is in there, Megan,
Yeah,
and all other leaders of teams, right? So you can bill for Child Life services. If one of your music therapists go out there, you can bill for that. It's just it was a lot of creativity from the individuals who have been advocating for this a long time. This also includes Patrice, Megan, and the rest of you. If you have the social worker that's going back therapeutic interventions rather than just, resource
Resources.
acquisition and a little emotional management. Under my interpretation, you can submit a billing code for that, saying it's in addition and it's going above and beyond the services that we provide from a palliative care perspective, which I think we can all agree for palliative care, it's highly psychosocial. And so having these aspects is it's so beautiful for the programs that have been doing amazing work to actually get some kind of compensation for all of that extra stuff that's been going on.
How about chaplain services? That's
That
probably not on here.
that is something I didn't see, Ellen. I don't know if you recall off the top of your head. I did not see that on there for a billable service.
So I don't think we're clear about exactly how that, I mean, bereavement support, I think there's a limit to, it's all within the year after death. And I think there's a limit of like a total of maybe 15 visits, but certainly you could bill for your chaplain to be doing those visits, I think.
Is bereavement support only after the death then? It's not pre-bereavement?
No, it does say stuff for pre-bereavement.
Okay.
Yeah,
Okay.
yeah. It's just that, so it's actually a really unique thing, right? For Medicaid, there are no other circumstances where Medicaid pays for a service to a person who is no longer alive, right?
Yeah.
And this is the first benefit they've ever really done where the unit of care is the family.
Mm.
So this is quite new for them. And the idea that the family continues to need services after the child has died in terms of their bereavement. And, again, we're still waiting to see if CMS will approve all this. And then how the billing is going to work is going to be a little bit of a process for the state to figure out. But they've already done tons of thinking about it. It's not like they're going to start from scratch when this thing gets approved. They've already thought through a lot of this.
Okay. Great.
And then provider qualifications. Actually, I'm going to just hit that last one. Providers must be licensed in the state as a hospice or a home health agency. Or, and I want to emphasize the or, because we realize that having hospices and home health providers as the only providers is probably not going to work very well. So other types of providers can be certified by the state and by the Medicaid agency to deliver pediatric palliative care. So they're going to create a new provider type for the state. And then if you are a hospice providing pediatric palliative care, then you're automatically in, right? You're qualified. If you're a home health provider and, you're doing this and you have the credentials, you're in, you get a provider type to do this. But, an FQHC could potentially, not that they will, but there's no requirement for other providers to get certified to do this, but it opens that door that if someone wanted to create a portion of their practice that they were dedicating to pediatric palliative care in the community, you wouldn't have to do it through a hospice or a home health agency.
Right.
Any questions about that? Okay, amazing. Let's move on.
It's actually incredible.
Sorry.
Oh, sorry.
I cannot figure out how to raise my hand, so I apologize.
It's okay. Jump in.
I've never been technology savvy. Scott knows that. But have you guys seen the Illinois Pediatric, the review instrument? Like, have you seen what a patient has to present to qualify? Is it pretty specific, or I'm just wondering how they're deciding what patients qualify for this?
Yeah. I'm going to go from memory here, and Scott, you may so qualifying is one thing, and then the full evaluation instrument is a second thing. Is that right? Okay.
Yeah, so the diagnosis will allow you to qualify, and then the needs. So they've created a assessment that will, and then they're going to decide based off that assessment whether you qualify for the program or not, based off the family and the patient needs. So it's not necessarily just the diagnosis that happens. The diagnosis gets you in the door. Then they create the assessment. The assessment, HFS and DSCC have worked to get a team together that's qualified in order to make those determinations based off their criteria. I'm with Ellen. I can't remember exactly what those criterias are, Sheila, but a lot of the questions were very similar to the things that we would ask when we would go in for our assessments. Let's talk about your medications. Who's your providers? Like what is the specific reasons for your need for this program at this time, since it is a limited program, you don't just stay on forever, right? And so you have to you have to meet the qualifications for their assessment. And I don't even remember the name of it. Do you,
We
Ellen?
can we can share, I mean, it's preliminary, right? Because we
Yep.
don't have an approval, but we can certainly share it. And again, I mean it's not necessarily locked in stone. I'm sure we're gonna learn things over time. But yeah, and we really tried to talk them through because their experiences with the medically complex and technology dependent waiver. And so the first thing they put together, we were like, no, 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 different population,
Yeah.
different issues. And so we really tried to help them make this more tailored to palliative care needs.
Mhm.
Um, but yeah, I don't have that form, real committed to memory, but we can certainly share the draft.
Yep.
That would be cool to look at,
Okay.
Yeah.
just to keep, just to know the scope of palliative care. Yeah.
Yeah. Yeah.
The-
Okay. And then I think our next slide goes over kind of what the responsibilities are to think through. And this is all laid out in the waiver, which means that like if it's in the waiver and the waiver is approved, you got to do it that way, which
Mhm.
is, could be a little frustrating, but this is the way that all of these things work, right? So the responsibilities that lie with HFS are administrative, operational, and quality oversight and monitoring. They ultimately have the last word in terms of eligibility and reevaluations. They notify the families if they you know, if they are eligible. They establish the technical infrastructure rules and policies and the guidelines. Um, they, within the impact system, which is their like software program or their platform, they get providers enrolled and certified to establish their credentials, and then they adjudicate claims under fee for service, uh, and they do prior authorization for services for when it's fee for service, and they handle appeals and state fair hearings.
So for all the individuals who are in the field, this is going to look very similar to the medically fragile and technically dependent waiver. HFS houses all the administrative tasks. They have to hire someone else in order to do it by law. They've worked with the University of Chicago in the DSCC program. And so this is going to be very similar to the structure of what that looks like. So I say that because there's already a template for how it's used. They have good relationships. They work together very well. So I'm hopeful that relationship will allow this also to function very smoothly.
Yeah, yeah, very much so. So yeah, then DSCC is involved in terms of processing referrals to the program, completing the initial assessment for the children that are referred, providing care coordination for those that are fee for service, and then maintaining and updating the assessments and person-centered plans for those fee for service kids. If it's kids that are fall within the MCO program, then the MCO program is going to provide the care coordination. That's going to be a little bit of a thing with hospices, right? We're used to like kind of taking over with adult patients. We take over that care coordination. But in this situation, the care coordination really does continue to, or does rest with the MCO. They maintain and update the assessment and person-centered service plan. Uh, they develop a provider network. They adjudicate claims if the child is on with the MCO. They handle any prior authorizations for services, and they handle any grievances or appeals. So it's split a little bit. And then providers submit referrals, collaborate with DSCC and the MCOs, collaborate with the care coordinators, provide clinical information and recommendations, and provide the covered services.
So before we move on, one thing I just want to be clear on is even if this passes, it doesn't necessarily mean that we're going to all of a sudden have palliative care providers throughout the state. And so the hope is that by passing this, there's more incentives. It's financially, it's just, it's very, very difficult to maintain a pediatric palliative care team when you're doing most of it through not like, basically pro bono work. And so what the hope is by passing this and then adding this collaborative to help with some of the questions or whatever the case may be, we're hoping that it does increase the amount of providers that are out there for some of these service deserts, especially outside the Chicagoland area. Lightweights covers 11 counties. They do a very, very good job, right? And they're providing services. There is no other pediatric specific team. The reality of the situation is there may not be another pediatric specific team in these other organizations. So this might end up having some adult providers come down. We don't know how it's going to look, but allowing them to say, hey, if you hire some pediatric individuals that also help with adults, maybe we can get some reimbursement for the work that they do both in hospice and palliative care. And so it's a structure that the state is really trying to do to remove some of these service deserts and increase the likelihood of services in those areas. So keep your fingers crossed. Please, reach out if you are an organization that's looking to learn more about this waiver and when it comes through, how it could benefit your organization. Okay. Any questions regarding that public service announcement? Beautiful. So now we're going to get into some of the legislation that's actually been passed or looking to pass that may influence you in your job. That's not the palliative care waiver. That's our SPA. That's a long process. We understand that. We just wanted to keep you updated because people have talked about it for years and years and years. And no one's better to do it than Ellen. She's been with the process the whole time. So let's move into some bills, both at a federal and state level, that could impact us.
And if we don't get to all of these, I will just let you know. So there are links in all of these slides that I'm sure that Scott's going to share with you. And so you can click on the link and it will take you to the full language of that bill. But these three bills were passed last year and were pretty simple. So they made it through the process in 1 year, but they weren't nearly as, you know, they weren't the pediatric palliative care benefit. That's like a huge lift, right? So that I walked you through how long that took. Not all bills take that long. So HB 2877 was called the Hospice Program Board Report, and it requires the state advisory board to submit a report to the General Assembly, just sort of educating lawmakers and making information available to agencies about the state of care for individuals in Illinois experiencing a serious life-limiting illness and their family caregivers. So we have to put that, there's certain requirements about what's got to be in that report. Many states do these reports. And so we wanted to push the state to create that report. It's not an ongoing thing, it's just a one-time thing. But we really felt like it would bring awareness around Illinoisans who have a serious illness and kind of demonstrate that there is a gap in care. And this applies to peds as well, right? There's just that gap in care that exists between like home care services. The person's going to get better, or they're going to, remain living for a long time with certain difficult conditions. And then hospice service, this patient is going to die within 6 months if the disease takes its natural course. So, there's a gap between those two. And what do we do about that? So we wanted to demonstrate to the state that community-based palliative care has a value. The second bill was a patient prescription pickup, super easy, right? It allows anyone who's employed by a hospice to or a home health organization to pick up prescribed medications on behalf of the patient and bring them to their house or place of work, including controlled substances. So just trying to make life a little bit easier. And then the third one was a POLST bill that requires the Department of Public Health to approve training resources to support those that are having POLST conversations, making sure those decisions and those conversations are informed and that the form is completed accurately. The POLST Illinois committee is actually the committee that's going to be or is creating those training programs, and then IDPH will run it all by their legal department and make sure that it complies with Illinois law, and then they will approve the training and we'll be able to use that. You can go ahead to the next one
Okay.
unless anybody has any
So
questions.
these are a couple of state laws that have passed. So House Bill 2464 was all about insurance health for neonatal care. So basically what this law states is that the individuals who are going to a NICU that's outside of their provider service area will be billed the same as if they went to the provider inside of their service area. And so they keep the costs the same. This is important in the state of Illinois because we have so many individuals that are traveling uh, outside of their communities in order to get the specialists that they need. So whether they're going to SIU from one of those border towns over by Iowa, or they're coming from Southern Illinois up to OSF or whatever the case may be. This is allowing you to get those services, those specialists at these NICUs for the same cost. Super important. The second one is HB 2974. Basically, this is a law speaking to the parents. So the parents, have historically had to use FMLA in order to be with their child if they're in the NICU. Now, this law states that if you're in a organization that has under 50, between 16 and 50 employees, then you are to get a certain amount of days. I believe that is 10 extra days that are not included in their FMLA. So anybody working in or around perinatal neo or the NICUs, neonatal, you have families that may come in to your organization. It's important for you to know this law so they know that they might have extra time. It's also important to utilize this if they're in the NICU and then don't want to use their FMLA so they can spend more of that time with their kid once they're discharged. So either way that you're working this law, it is supposed to be beneficial. So the bill has been, really talking about leave can be continuous or intermittent, right? But you have to have at least 2 hours so that we're not messing with the employers. But it is important to know that, okay, you're going to take this time. It's unpaid, but you're still going to get your full FMLA if you use a certain time. So if it's over 51 employees at your organization, I believe it caps at 20 days. Uh, the next one is about early intervention. Early intervention is incredible, right? And families, absolutely love early intervention for several reasons. It delays symptom progression, right? It enhances functioning, whatever the case would be. So this bill is focused on ensuring that any individual that's under 1,000 grams is absolutely mandated to be referred. It's trying to be the stopgap for those individuals that weren't referred and make sure that those families are getting the services that they need. So the ultimate goal is to improve access to early intervention services for infants in the NICU by strengthening the referral and information process, right? So, and this all has to be done before hospital discharge. So the mandatory information sharing standards were created in here for hospitals as part of an automatic referral process. So the bill basically says that this is an automatic referral if this child is born with at this size or this level of gestation, right? And then now you have to refer, and this is the information sharing that we're mandating. So it addresses the gaps in care for those eligible or high-risk infants that were not, directed to critical care development services in a time-sensitive manner, because we don't want to lose any of the functioning during that time that it takes. Any questions regarding those three? Super exciting, I think. This is unbelievable, right? So these three are all really directed towards, early stages of life. Now, some of the federal laws that we're looking at, one of them, the middle one, let's say, stays in that realm. So this regards to pretty much perinatal services. So on December 16th, HHS Senator Robert F. Kennedy approved the addition of Duchenne's muscular dystrophy and MLD to the recommended uniform screening panel. Right. This is incredible because, we all know that Duchenne's doesn't happen right away. Right. And then some families actually have a second child before they even get the first diagnosis. And now you have two children in your home with the same diagnosis because it is genetic. And so what this is saying is that, most of these individuals are diagnosed later, but research would say that if we get early services for these individuals, we could, prolong their higher level functioning. We can slow down the disease progression, and we can get them into this, the level of functioning that hopefully improves quality of life and extends life. So this addition helps children retain the ability for their abilities for longer periods, while giving families a better chance to avoid the long delays, repeated specialist visits, and the financial and emotional strain. Early screening gives children and family a fair chance at timely, effective care, and it delivers families the answers and the treatment options that they need. So this is incredible, right? And then, in addition to that, Ellen and I were actually in DC late last year, talking about this Consolidated Appropriations Act. What this is there's a telehealth feature that it started in COVID. Am I right, Ellen? Yeah.
Yeah.
And so,
Yeah.
and it started in COVID for health reasons, but it also has really helped our rural communities to provide services to a larger reach of individuals. And so that bill, I think was it expiring in September of last year?
Well, each time we ran out of a budget bill, each time we hit a roadblock with the budget bill, we had these telehealth
That's right.
flexibilities expire. So in the fall, hospice providers had to go back to doing face-to-face recertifications in person for, I don't know, a month and a half or something like that, whereas they hadn't had to do that since the COVID pandemic. And then, so now this makes, and this has to do with palliative care too, because services, they didn't have the flexibility to engage in a telehealth visit, right, that was geographically initiated from the patient's home. So it had to do with, how do you conduct telehealth? For what purposes do you conduct telehealth? So finally now there's been a more permanent extension, and specifically for hospices, they can use telehealth for those face-to-face visits through the end of 2027.
Yep.
They are going to put in place a code where recertifications that are done by telehealth are going to be coded differently, so they can look at the length of stay of people that are recertified via telehealth versus in person.
Which is smart.
And they also have, though, if hospices are sort of under extra scrutiny by the federal government, then if they're a new hospice or the hospice has changed ownership and is in a high risk state, they're not going to be able to use telehealth for this purpose. So it's not exactly straightforward. If you need information, if you're a hospice, you have this information, a lot of the details. But at this point, for the hospices in Illinois, this extension of telehealth services is in place.
And then we're getting close on time, so I want to make sure we're highlighting a couple more things that were passed. The Michaela Nayland Give the Kids a Chance Act was something that was signed into President Trump signed it in this bill on February 3rd. Basically, what this bill is doing is expanding cancer treatment options as well as therapeutic interventions for rare diagnoses. Right. So this is something that's been in the works, much like our palliative care SPA. It's been in several different forms and working and going. This is incredible for those families that feel like they've exhausted all treatment options and whatnot. The other piece that comes with this bill, and this is a federal bill, right? So the other piece that comes with it is money for continued research or additional research inside of cancer treatments as well as treatment interventions for rare diagnosis. So it's extremely exciting that this got passed. That's in addition to the Accelerating Kids Access to Care, which was also signed at a federal level on February 3rd. This bill will require Medicaid programs. Basically, what this bill does is it cuts out the pre-authorization needs for families that are looking to get treatment outside of the state. Right. So it's mandating that Medicaid creates contracts with different like providers that meet the criteria that they have so that the families don't have to wait and delay treatment oftentimes in crisis in order to get the Medicaid approval. So this bill can assist families with complex medical needs to get specialists faster, especially if the care they need is across state lines. Currently, there's a lengthy Medicaid approval process. This will force state Medicaid to conduct a 5-year agreement with out-of-state providers to alleviate red tape. So that's very, very exciting. This is something that we advocated for in September. And so if you think about it, those last two bills we were pushing, and I know that it seems like it's a long time and not many get passed. This is something that we definitely influenced. Go ahead, Megan.
All these bills that passed,
Mhm.
it sorry, it covers Medicaid, correct? This is not for
Yep.
private insurance.
That's
Okay,
correct.
thanks.
And then just because a bill get passed doesn't mean the effective date is right away. So I think this bill doesn't start until January 1st, 2027, right? And so I think they need time to get the contracts going or whatever the case may be. But you're right, it is usually Medicaid based. And the last one we threw up there it's not federal, it is an Illinois-based Senate bill that was recently put into a public act or a law, and it is insurance codes for equine therapy. And this is super exciting for those individuals that may have, complex care needs or, some of our palliative care patients that are at home for long periods of time and their parents utilize some ancillary therapies in order to meet those kids' needs or give them what they want while increasing their quality of life. So this is extremely exciting. It expands treatment options for children with medical complexities. And then we added these two. This one, Ellen and I talked about this one right here, and Ellen's just like, "What are we doing with this Batten Disease Day?" The reason I put it because it really does nothing for the families outside of giving them hope, right? And saying that I feel seen. It's a big deal. We're glad we're bringing awareness to it. So this one wasn't passed. It's still in consideration. But we put this up here just to let you know that this is the way that all those days that we celebrate get completed, right? And that the families do feel heard. Now, this last piece is something that is important for us to talk about. Right now, there's a significant nursing shortage, right, in the state. And so we're really talking about those individuals with private duty nurses at home. And so the state has talked about several different ways that we're going to alleviate that problem because we realize that we can't just hire nurses, right? It's not everybody has a shortage. There's not a huge pool to choose from. So this one over here is HB 2369. This was actually put forward by Lindsay LaPointe. right? Who is a licensed clinical social worker, graduated from University of Chicago. She's amazing. And so what we're looking at here is her proposal for the problem was that families shouldn't have to get a CNA. What they should do is meet the criteria that HFS creates, and then they can just get paid to be family caregivers, right? They call it the Family Health Aid Program. That wasn't passed, but it is suggesting that people are looking at solutions for this, right? Conversely, DSCC and HFS are currently looking into a certified nursing assistant program, which is a CNA model for families. So right now, what was it, 2 years ago, Ellen, maybe three, that or maybe during when COVID started, that um, parents who are nurses could subsequently get paid to care for their kid at home if their kid got private duty nursing hours through DSCC. This is the program for those individuals that hadn't taken that career path but are having to stay home. Right. So what they would have to do a CNA model, there's one in Colorado, like Ellen was saying, you look at other states, there's one in Texas, and this would say that you would hire on to whatever organization you have, you would take their classes to become a CNA, and then subsequently you could utilize your CNA certificate to fill some of those unmet nursing hours. Right, this does two things. It obviously provides the care that your child needs who's on the DSCC waiver or the medically dependent technically or medically fragile technically dependent waiver, but it also fills the gap for those families that had to have go from a two-income house to a one-income house, and they're simultaneously being able to take care of their kid while getting some kind of income to subsidize that money loss. Both of these are great options because these families are in significant need, but neither one of them, the Certified Nursing Assistant program is at a CMS level. They're looking to see how that would work, and DSCC is working with them on it, while politicians are also saying, hey, there's other ways if that doesn't pass. So both of these are very exciting. I know this is something that a lot of providers out there in the field experience, families frustrated that they were approved for 70 hours and only get 7 or whatever the case may be. People are looking into these through either waivers, laws, or whatever the case may be. And so these are just two of the options. So Ellen, I think we've ran a little bit out of time, right?
Yeah.
So we will send this to everybody. But we wanted to make sure, I can't thank you enough for coming to our very first session. I do have another poll that we are going to put up to see if we were able um, to achieve our goal of extending knowledge base and really providing a forum. So if you could first of all, Ellen, you're incredible. Thank you so much. It's
My
just
pleasure.
such a
Always a pleasure.
pleasure.
I put my email in the chat for anyone that wants to connect on specifics.
Yeah, please reach out to Ellen. Like I pretty much reach out to her with any question I have regarding legislation. She's incredible. And thank you so much. If you can complete the poll before you leave. And then Megan, did you want to put the survey in if anybody wanted their CEUs into the chat?
It's already in there.
You're fantastic. Thank
Yep.
you so much.
And please feel free to fill it out. Even if you aren't looking for CEUs, you can fill it out anonymously because we love the feedback.